Hello, and a very warm welcome to this London Global Cancer Week session entitled Could the Findings of an Ovarian Cancer Patient Experience Study Benefit the Wider Community? My name is Annwen Jones. I'm chair of the World Ovarian Cancer Coalition. For those of you who may not know us, we are a partner organisation with over 200 members drawn from many different countries who share an interest and a commitment to improving quality of life and survival for women with ovarian cancer. Today, with our strategic advocacy partner, the International Gynecologic Society, Cancer Society, we are delighted to share with you early findings of the Every Woman Study Low and Middle Income Country Edition. You will hear from women in the countries that participated, from clinicians who participated, and you will hear the latest results from the ongoing analysis by Dr. Garth Funston, member of the data subgroup involved in the study. We'll talk about diagnosis, about treatments, care, emotional needs, and women's priorities, and ask you to consider as we go through. Firstly, if you're not directly involved in ovarian cancer, how do the results resonate with your experiences and desire for change? Can the voices of women with ovarian cancer, either in person or through their data, support important global calls to action in cancer and gender equity? Secondly, if you are involved in ovarian cancer, what is important in your setting? And how might the data from this study inform your actions and your advocacy? Please do submit any points or questions by the chat. We will hope to raise some of these during our panel discussion, for which we have three very eminent guests: Dr. Julie Torode, Dr. Ophira Ginsburg, and Her Excellency Dr. Zainab Shinkafi Bagudu. Thank you all. But first, to set the scene about the study, I will hand over to my colleague, Frances Reid. Frances is Programme Director for the World Ovarian Cancer Coalition and lead for the Every Woman Study Low and Middle Income Edition.
Thank you very much. What is the Every Woman Study? Well, it is a multi-country observational study exploring the experiences of women with ovarian cancer. We look at diagnosis, we look at symptoms, we look at treatment options, we look at how that impacts on women emotionally, practically, financially, and we ask them very many questions, including their priorities for action. The study aims to reveal the challenges and opportunities to improve diagnosis, treatment, and quality of life for women. It was first developed in 2018 and ran as an online survey. We had 1,531 women from 44 countries participate, and you can see the countries there on the right-hand side. And the larger the lettering, the more the number of women who participated. Our results were published in the International Journal of Gynecologic Cancer, and we showed that there were a common set of issues across all of those parameters that we had set, but each country had a different mix. So some were really good in some parts, such as time to diagnosis. Others were really good in access to treatment, but they had significant problems in other areas. No one country was without significant issues. So that gave us the idea that we have the potential to learn from each other. So why do an LMIC edition? Because there was basically a huge data gap. 95% of our respondents came from high income countries, and that contrasts greatly with the fact that 70% of women in the world who have ovarian cancer live in low and middle income countries. Globocan predicts big increases in incidence and mortality, over 50% and nearly 70% respectively. But actually, when you look at the increases in low and middle income countries, they're considerably greater. So it's really important that countries have good data on which to base their plans to tackle this disease. So how did we make it suitable to run in LMICs? Basically, we had to go through hospitals. There was no way we could reach enough women without them. And this is where we partnered with our strategic advocacy partner, the International Gynecologic Cancer Society. Between us, we identified 24 country leads, and 22 of those were successful in getting ethics approvals and getting their teams together. In fact, we had 82 hospital teams take part in the study who were trained in the background of the study, the questions, and trained in REDCap. We did adapt the survey from a very, very long one to just a long one to fit into clinic schedules, and we asked for clinical information as well from the clinical teams. We made it available by email, by WhatsApp and Telegram, by paper copy in the clinic, or by having somebody interview the woman in the clinic themselves. And the study and the interviews were available in 28 different languages. These are the countries who participated. They are all lower middle or upper middle income countries, but here we've organised them by HDI, Human Development Index. Women were available to take part if they'd been diagnosed within 5 years of taking the survey, if they were 18 or above on the date they took the survey. They were only allowed to participate if they'd been previously diagnosed and that they were considered well enough physically and mentally to participate in the survey. We have already published our protocol in +1, and we are thrilled to say we had 2,446 women included in the analysis. And here you can just see a little bit more about the proportions of the women who took part by Human Development Index and the numbers for each country. Before we get into the results though, we are going to hear from women in these countries, or some of these countries, about some of the issues that they see that are paramount.
My name is Stella. I am from Nairobi, Kenya. I am a teacher and I'm married with 4 children. I think the biggest problem is financing the treatment. It's actually very expensive. And for one, many women in my country do not have employment. They are housewives at home. So I want to imagine it's a big problem because even for me, before my insurance came in, I was just wondering because the treatment was taking almost what I earn in a month. But I was lucky because my insurance was paying for the chemo sessions and any other tests that I was taking in the labs. I know finances are a big problem for many women, and most of them could be diagnosed when it's too late. Even after they have discovered the problem, because I see even with the rest of the people who get like breast cancer, most of them do not survive because they start treatment so late because of raising the funds.
Mi nombre es Laura, tengo en la actualidad 55 años, vivo en Medellín, pero nací en Bogotá. Entonces, para mí no hubo dificultades en cuanto a transporte o a dificultad de acceder a los servicios médicos. Afortunadamente cuento con una póliza aparte de mi afiliación al sistema de salud colombiano. Entonces, pero yo soy un porcentaje muy pequeño de la población. En general, las personas que sufren no solamente de este tipo de cáncer, sino de otros que se encuentran en sitios remotos, alejados en el país, con dificultad de acceso a los servicios porque no se cuenta con los especialistas, porque no hay los médicos suficientes, o porque no tienen las condiciones de transporte hacia las ciudades, pues son las personas que realmente enfrentan grandes retos.
Hi, I am Nimki Gupta. I live in Luxembourg. I'm an Indian. Right now I'm in India, in a city called Bhopal. It's in the center of the country. I am an ovarian cancer patient, high-grade serious ovarian cancer, stage 3C. Now, the stigma and the taboo around cancer in India comes from multiple things. One, like I said, it's a fairly new phenomenon in India. And in India, if you don't know about something, the best approach is to keep quiet about it, which means doctors don't talk about it, patients don't want to talk about it, and the family members don't understand it, right? In India, we have a very strong family system. It's, I don't know how many of you know, but probably you've heard that even today, I know of my friends where 4 generations of a family, they live together in the same house. It's that strong. Flip side, there is no palliative care, or let's say the palliative care for cancer is negligible because parents live with their children, children care for their parents, parents care for their children. There are a lot of cases where the family doesn't understand what the patient is going through. People outside the family don't understand what the family is going through. And when things get really bad, they don't know where to go because there are no hospices or palliative care centers in India. Cancer is a full body disease, and beyond the patient, it is a family disease. Not everyone dies, but everyone suffers. So getting a doctor who understands all aspects of how cancer is impacting the patient and the family, it's nearly impossible. And if you don't have doctors around you, you just can't find the right person.
Hi, I'm Irene Lau here. I'm from Malaysia. Currently now I'm residing in Subang Jaya. In Malaysia, we don't have a specific oncologist who is specialized in ovarian cancer. It's different, I think, when you have a specific oncologist who really knows the symptoms and how to focus and make the line to treat the ovarian cancer. In Malaysia, we still need a lot more to shout out to the public about this. So that's why having a study, the ovarian cancer patient study, that is a very good thing to make to make the awareness among the doctors as well, the oncologists.
Our thanks go to the women for sharing their thoughts in that video, and indeed each and every woman who has contributed to the study as it was developed and then in the data collection phase. And we have an awful lot of data still that we can analyse and look through, and it'll keep us busy for quite some time. But we do have some interesting and important findings so far. And to present those, please welcome Dr. Garth Funston. He's Clinical Senior Lecturer in Primary Care Cancer Research at Queen Mary University, London. He's a member of our Oversight Committee and a member of the Data Subgroup.
Thanks, Frances. So before I delve into some of the headline results, I just want to touch on the type of data that we collected in this study. So collected data in 2 different ways. The primary way was the patient survey. So this was the survey conducted by either patients filling in the questionnaire online or in interview form. And we asked 59 questions across 6 domains. So we connected information on demographics, family history, so family history of things like cancer, the journey to diagnosis, so the symptoms women had before they were diagnosed, their knowledge of ovarian cancer, also experience of treatment, were they involved in decision making, the side effects, their support needs, and I think crucially what they feel their priorities are to improve care within their country. 59 questions, hundreds of thousands of bits of data generated through that, but we supplemented that with data collected from the clinical notes. So this is key information on things like diagnosis date, morphology of cancer, and the tests and treatments women had. You'll be pleased to know I'm not going to talk about each of these aspects in depth, but what I do want to do is do some summarizing of some of the things we found and pull out some key early findings. So we'll look at the participants and cancer characteristics, think a little bit about the journey to diagnosis and their experiences, the treatments women had, touching briefly upon that, genetic testing again, touching briefly, and then thinking about the impact of the condition and the treatment on women within this study and their priorities to improve care. So participants and cancer characteristics. The median age of women within the study was 51, some variation by country, and I'll show the lowest and highest countries within brackets throughout the talk. But we saw pretty marked variation across multiple background and demographic characteristics by country. So pulling out a few here in terms of education, 12.2% reported having no formal education overall, but this varied really markedly from no patients with no formal education to 61.7% of participants in some countries reporting no formal education. But also differences in countries between things like how long it took patients to get to the hospital where they were treated. So just picking out greater than 5 hours journey time to the hospital. Average was 14% experiencing that, but this varied from no patients in some countries to half of patients in others. And we saw this across lots of different characteristics within the study. Thinking about the types of ovarian cancer included, as we would expect for ovarian cancer, the majority of women had an epithelial cancer type, and the majority of those, the most common cancer type within that group was high-grade serous, at 44%. But we saw quite marked variation on the proportion with high-grade serous cancers. And I think one of the explanations for this is that in some countries, actually, the type of epithelial cancer wasn't available to the clinicians. So in some countries, up to 50% were simply categorized as unspecified epithelial cancer, which has implications for both prognosis and treatment of these women. Looking at stage, again, the majority of ovarian cancers were diagnosed at a late stage, so stage 3 and 4, as we would expect for both all ovarian cancers and high-grade serous. But again, there was variation between countries. And in particular here, we saw that low-income countries had a greater proportion of earlier stage cancer. And there may be some survivor bias in here where patients, we aren't capturing the patients with advanced cancer within those countries. So next, thinking about the journey and the process of diagnosis for women. We looked at awareness of ovarian cancer in depth in some of the questions, and we found that the majority of women within this study had not heard of ovarian cancer and reported knowing nothing about it prior to their diagnosis. But again, a theme for this presentation is there is really interesting variation between countries. So this chart shows the awareness of cancer, not symptoms, by countries, and just pulling out some findings here. No need to take in the whole chart, but in Uzbekistan, for example, if we look at the blue bar, the majority of patients had heard of ovarian cancer and knew something about it. In some other countries, that was much lower. The awareness was much lower. And I think there's really interesting findings here to be delved into what's going on in these different countries, and that's ongoing. We also looked at factors associated with greater awareness of ovarian cancer using ordinal logistic regression models. And perhaps unsurprisingly, some factors that were associated with higher awareness were things like higher income, higher education level, and higher HDI group. But I think perhaps the most interesting thing is to look at the variation and see what we can learn at a country level. Secondly, thinking about symptoms. So there's been lots of work done in high-income countries defining the symptom profile of ovarian cancer, but I'm not aware of any work done in lower-income countries. And in this study, we found that the majority, so over 90% of women, reported having one symptom, at least one symptom, of ovarian cancer. And we looked at this by presenting women with well-recognized symptoms of ovarian cancer and asking them what features they experienced before their diagnosis. The most common symptoms were abdominal and pelvic pain. 66% of women experienced that, and persistent bloating or abdominal distension. And again, a majority of women experienced that. These are also the most common symptoms in the literature, but the bloating rate here is higher than in other studies in the past. Next, we look at the symptoms by stage of diagnosis, and we find that although some symptoms were more common in later stage, so stage 3 and 4, such as bloating, actually symptoms were common across stage of diagnosis. And a key takeaway from this work for me is that 85% of women reported having at least one symptom, and that's in women diagnosed in stage 1. There's still a bit of a myth that ovarian cancer is a silent killer in some areas, and I think this kind of certainly refutes that and is important when thinking about symptomatic detection in different countries. Next, we find that the majority of women with symptoms sought help for those symptoms, and most women sought help from a gynecologist or their family doctor or GP. But a significant proportion went to a local healer first. So 1 in 20 women, the first person they visited was a local healer. In some countries, this was much higher. So 1 in 4 women in India visited a local healer. We found that this was associated with having no insurance or family members paying for care. Diagnostic intervals, it's one of my interests, and I could talk about this for the whole session. We're looking at this in depth at the minute, but I did just want to pull out one key finding from what women reported. And 38% of women in this study reported that their time to diagnosis could definitely have been shorter. And they cited a number of factors, which I think it will be common amongst healthcare systems, such as reduced healthcare system delay, but also factors such as financial issues, which they found were potential barriers and contributed to delayed diagnosis. Next, I'm going to touch very briefly on treatment extracted from hospital records. We're going to look at complete cytoreduction surgery, because it's a key metric when thinking about prognosis in ovarian cancer, and touch on chemotherapy as well. So we asked for information on complete cytoreduction to be extracted in line with guidelines on this. And we find that the majority of women across countries had complete cytoreductive surgery, which is, I think, a really positive finding. Again, massive variation between countries within this study, with it being very common in some countries, such as Argentina, and less so in others. Chemotherapy, again, collected lots of information on this that we're looking at, but the majority of women were treated and received chemotherapy, and here we excluded women who had a very recent diagnosis and so might not be expected to have treatment yet. But massive variation by country. So in Malawi, only 25% of women had chemotherapy. In Uzbekistan, all women in the study sample had chemotherapy. Touching very briefly on genetic testing, genetic testing has become standard of care in many countries. It can happen in women whose family members have been diagnosed with a BRCA-type cancer, for instance, but also it's important in women who've been diagnosed with ovarian cancer themselves. to help guide some of the more targeted treatments available. We found that in women who pre-diagnosis, that actually rates were low, which isn't unexpected. So only 1.7% of women in our study had testing for genetics before their diagnosis, but it is happening in some countries. Post-diagnosis, rates are higher, so 18% overall, and this is, I should say, in women with an epithelial type cancer. Seems to be very standard in some countries, Argentina, for example, but no post-diagnosis genetic testing at all in others. Lastly, thinking about the impact of diagnosis and treatment on women and their priorities. So in terms of impact, again, we had multiple questions looking at lots of different aspects, but just pulling out two here. Looking at the emotional needs of women, women cited that these were strongly driven by aspects of fear, such as recurring disease. Only a small proportion had psychologist input, which is again becoming standard in some countries. The financial impact seemed to be very significant. So 45% of women reported their family finances have been affected. And perhaps the most striking finding for me for the whole study is almost a third of women said that their family income had fallen below the level they needed to live on. Thinking about priorities, we provided a range of options for women based on our patient groups and expert panel. And these are the 5 main priorities that women said they would want to see if money was available to invest within their country. So the first 2 focusing on early diagnosis, really. So developing of screening programs, free access to diagnostic tests, but also things such as free access to treatments and awareness of symptoms were really important for the women within this study. So I think this program has a number of strengths. Firstly, the diversity of countries which were included and the scale of the project. We've captured data from 22 different countries in 82 languages, and that allows us lots of data to compare and analyze here. The breadth of the topics covered as well, we've covered across 6 domains, the whole pathway from before diagnosis right up to after diagnosis and treatment, and we've covered lots of these topics in depth. I think for me, the kind of key strength here is that it's a true international collaboration, bringing on board women, clinicians from around the world, and that's been essential because we can go to clinicians if we don't understand something within the data and have a discussion and understand why that's happening within a particular context. Our approach does have some limitations. As Frances said, we aim to maximize inclusion within this study, and we applied a range of different options for recruitment and data collection. That does introduce potential biases, and that's something we'll have to take on board in our analysis. So in conclusion, I believe this work can help us understand the experiences and the priorities of women in lower and middle income countries, and also help us understand their diagnosis pathway and their treatment pathway and what's happening there. Because of including such a range of countries, it allows us to look at things on an international level, regional level, and also a country level to identify both challenges and opportunities at different settings. I think it could be really useful in helping to direct future research, it already is, but also to support advocacy and policy. And a key aspect of this is individual reports going back to countries to help them direct their future work. And it's helped us build collaborations around the world with different partners. And hopefully we believe that this could potentially act as a template for future work in other cancers and other diseases to improve our knowledge within lower and middle income countries. As Frances mentioned, this has been a pretty epic undertaking involving hard work from loads of people, and this just highlights some of them. Thank you.
Thank you so much, Garth, and all the members of the data subgroup for all your continued work. Well, we've heard from women in some of the settings, and we've heard about some of the captured data, But what about the clinicians who led to the study in participating countries? What did the experience bring to them in their clinical practice? How has it affected their thinking? The next video will share some of their thoughts.
I'm Tracy Adams. I'm a gynae oncologist and I work in Cape Town at Groote Hospital and the University of Cape Town. Sometimes we think something can't be achieved, but if we stand together and come up with ideas together, including people from different countries, things can be achieved. And that is what the Every Woman study has done in terms of bringing a whole lot of countries together. I don't think that we can look at cancer, especially cancer in women, in isolation. And we can't look at it through one perspective only, in terms of a perspective from a high-income country or from one specific country. I think studies should include women from all socioeconomic backgrounds, or ethnic or genetic, and from a multitude of countries, because cancer in itself is multifaceted. Add the dynamic of being a woman and being a caregiver, to kids or to elderly parents. So we also need to remember that the policies of countries differ. So you can't use one perspective. The financial support differs. The diagnostic tests and treatments differ, and what is available. And so support women receive may also differ in terms of culture and what people believe in.
So my name is Basil Rifki Abdel Fattah. I am an assistant professor of surgical oncology and gynecological oncology in Oncology Center, Mansour University. Patient experience is the cornerstone, as you know, that's the heart of all the medical practice is the patient care. And everything should be patient-centered and prioritization of the patient care rather than what we as doctors or physician or surgeon would like to do. So putting the patient in the context of a clinical trial and the studies, really I see this is simply the heart of medical practice. Diversity in patient care in between different regions, in between different cultures, in between different resources, this should be thoroughly discussed. This should be thoroughly studied. So simply we can't replicate what the guidelines and the evidence and the standard of cares in a place or in a region or in a society and then replicate it in another region. That's why we have to see the difference in everything, in the resources, in the cultures, in the religious backgrounds, in the financial aspects, and even how the patient look for the importance of life. We have to study all of this. We have to inform all our health practitioners that the patient is the core of our work. Simply, we work for the sake of the patients. So studying this diversity, seeing what's happening in South America, what's happening in Africa. Africa is very large, for example. So what's happening in Egypt is totally different from what's happening in South Africa or in Sub-Saharan Africa, for example. Seeing the resources, bridging the gap, trying to give the minimum standard of care for them. I believe this is a very, very valuable story.
I am Dilara Kaidarova, Kazakhstan Chief Oncologist, Director of Kazakh Institute of Oncology and Radiology. I am from Kazakhstan, Almaty. At the same time, I am gyn oncologist. The diversity of patients' experience data is very useful and important and may depend on their age, the stage of the disease, geography, and the availability of resources in each country or region. In many countries with limited resources, the main attention is paid to treatment, but we should also not forget about the psychological state of the patients. This will allow us to study their inner world more deeply and prescribe individual treatment for them. During the Every Woman study, we heard about problem of organizations of cancer care in our country. And during the last 6 months, we installed the green corridor, and our oncology can put diagnosis during 30 days. And the Every Woman study has had a huge impact in understanding the equality of not only treatment for patients, but also their support in all level of their treatment.
My name is Ngọc Phan. I'm a GYN oncologist from Da Nang Oncology Hospital in Da Nang, Vietnam. There are so many lessons that we can learn from the Every Woman study in LMIC. Two-thirds of the patients has a lack of knowledge about their ovarian cancer, and like we can have the strategies on multimedia communication, so that we can bring the knowledge, the information about the ovarian cancers to the community better. And another lesson is like more than 95% of the patients have had the symptoms before they come to the hospital to see the physicians. And so if we pay more attention to multimedia communication and patient advocate, so that we can help and support the patient, and they may detect the disease earlier than in the study. There was less than 5% of the patient can access the targeted therapy. So from that, I think we can improve the policy for the ovarian cancer patients, so that the patient can afford their treatment care and decrease their financial burden for them. Also, a pharmacy company also can have some intervention to decrease the price of the targeted therapy, and have the patient can be involved in the clinical trials, so that they can access to the targeted therapy better than now.
So I am Dr. Aisha Mustafa. I work at the Gynecologic Oncology Unit at Ahmadu Bello University Teaching Hospital, Zaria, Northern Nigeria, and I am the country lead for the Every Woman Study Low and Middle Income Countries edition. I am very grateful to have participated in that study. I feel very fulfilled because the study seemed like a gateway for me to say those things I have been trying to say to the world, and I couldn't find a medium to say it. I didn't have an opportunity, for example, as an individual managing ovarian cancer patients, to stand on the podium at a big conference to say, these women need this. But the Every Woman study provided that opportunity. It spoke about us. It spoke about, it said what I wanted to say all these years that I didn't have the opportunity to say. It brought it out in a very formal way, in a form of a survey and with evidences. You know, before I would just say, okay, these patients need this, they need that, but it's just all verbal. But the Every Woman study said what I wanted to say in a very loud voice. And I want to say thank you that I was part of that study. And I'm not happy for me, I am happy for us as a nation, for my patients, that their voices are now being heard. And I believe that moving forward, the Every Woman study will actually serve as a stepping stone to even further collaborations, more research, more impact for patient care. And I actually see it opening doors for even our policymakers in Nigeria to recognize ovarian cancer as a huge burden and begin to listen. Before, nobody talked about ovarian cancer in my country before the Every Woman study. But as we speak, policymakers are getting interested. They're not just getting interested, they are signing memoranda of understanding for genetic testing for ovarian cancer. So, I mean, it's been just a couple of years, but the impact has been so enormous. So I just want to say thank you. And I honestly look forward to even further collaborations to see that, yes, ovarian cancer will not be as abysmal as it currently is in my country. Thank you.
Very powerful words there from Dr. Aisha Mustafa in Nigeria. So I hope you get a feeling that this study could be very important for the ovarian cancer community in these settings. But how can we turn data into action? How can we connect and amplify ovarian cancer voices into the global advocacy world? And are there things that they can learn from our approach? Well, that's going to be the sort of subject area, if you like, of our panel discussion. So I'm going to hand over to our eminent moderator, Dr. Julie Torode. She's board member of the Institute of Cancer Policy and also now the World Ovarian Cancer Coalition. And she's Director of Strategic Partnerships, Community Engagement, and is a visiting researcher and lecturer at King's College, London. Julie, before you introduce the others, what were your initial thoughts on what you've seen and heard?
Thanks very much, Frances, and congratulations to everyone involved in this fantastic study. Yes, my first impressions were, wow, what a powerful study bringing the true impact of ovarian cancer on women's lives around the world into sharp focus. These data really bring it to life, and for me, the determination that every single one of those patients had to get, firstly, their symptoms recognized, to get diagnosed, and even get to the point of being treated. And you have to applaud those women who've really fought for access to treatment. Secondly, Nimka's comment in her video presentation really got to me. Not everyone dies, but everyone suffers. And it really hurts me as a cancer patient to hear something like that. And, you know, you have to challenge our policymakers to say what sort of health system thinks this is okay. We cannot accept this status quo. So I really hope we can transfer that irritation, that anger to patient advocates to really challenge our policymakers to start to address some of those gaps and barriers that are achingly obvious to see. And the reason I'm so angry, and you can see I'm quite emotional, is it's a new study with new information, but it's telling us the same thing. The same thing we have learned from several other studies in different cancer types. So it's really about us using these data to challenge our health system leaders. So Frances, thank you for getting me riled up. And I think this is a great segue into our panel discussion, asking the question, are there wider implications and opportunities for the global cancer community? So I'd like to welcome my panelists, my co-panelists, Her Excellency Dr. Zainab Bagudu, Chair of the First Ladies Against Cancer, CEO of Medicaid Foundation in Nigeria, and President-elect of UICC. Welcome, Zainab. I'd also like to welcome my good friend Ophira Ginsburg, a clinical oncologist and Senior Advisor for Clinical Research at the National Cancer Institute Center for Global Health in USA, and Chair of the Lancet Commission on Women and Cancer. So thank you also for joining us, Ophira. So reflections on this study. Ophira, let me go to you first. What can this study bring to the table in terms of women's health and global cancer agendas, and particularly in the light of your own work in the Commission?
Wow, thank you so much, Julie. Thank you, everyone, for your important sharings. I have to also say congratulations on this exceptional piece of work, and I know it's really just the beginning. Well, my initial reflections are also almost tearful. I have personal and professional experience with ovarian cancer as a medical oncologist and treating patients in the past, and also a cancer geneticist, seeing many women with ovarian cancer coming for genetic testing and reflecting on the many, many women who never come for testing, even in settings where it's available and affordable. So there's a lot to unpack here. But putting my Lancet Commission on Women and Cancer hat on, which we actually named Women, Power, and Cancer when it came to the writing of the report, this is really the key reflection for me, is that we recognize that women are experiencing asymmetries of power in multiple domains, but we focused on three that is relevant, I think, to this discussion: information, access to information, decision-making, who has agency to make decisions for themselves, and about power in decision-making, and in terms of economics. Economics on the macro scale, sure, there's much more we need to do to show countries how much they need to invest in women and women's health and what those returns are, which we shouldn't have to think of women as just economic returns. There should be a right to health and well-being. But beyond that, the microeconomics and the financial toxicity associated with treatment and the inability of women, even if they can make a decision to go for care, even for the diagnostic workup, they may be having to say no to competing priorities such as children's health and welfare, et cetera. So many things to unpack here. Very important to have women at the center, people with ovaries, not just women, people with lived experience at the center, as we are reminded time and time again of that primacy of the lived experience. This is the first study of its kind that I've seen. I think the rest of us working in other domains of cancer care and control, not only for women, by the way, have a lot to learn. So thank you.
Absolutely. It's much more granular. And I think, Garth, you mentioned you want to dive more into that data. So we're really excited to see what other findings might be coming out. Zainab, let me turn to you on the point that Ophira's just made about including voices of ovarian cancer patients, bringing those voices to the global table and the policy table. Do you think ovarian cancer patients are ready to support the common issues that this study is revealing? And what would your recommendations be to grassroots civil society groups? How can they bring this broader language into their advocacy for ovarian cancer?
Well, thank you, Julie. And again, I'd like to reiterate the congratulations and kudos to the organizers of the study, the Ovarian Cancer Coalition, and all the investigators in the countries across the world. There is a very, very important place for having patient advocate voices, those with lived experience as advocates when we talk about cancer in particular and in low middle income countries, because of the various reasons that we have heard through this webinar. We've heard from the patients themselves. We've heard from a lot of the investigators, and one common thread that we have with ovarian cancer is the poor awareness and the stigmatization that comes with it. So when you hear from patient voices, they have that ability to show that, hey, this is real. And as Dr. Aisha brilliantly put it, the study gives that platform to be able to amplify what so many women are going through and what they're feeling. And I think that to go to the second part of your question, beyond having that ability, how can we get it to the grassroots? The study is one beginning, but we have to get our clinicians, we have to get our policymakers, and that is the hope, that the findings from this study will be amplified in a way that policymakers will get a hold of it, understand that this is an emergency, this is a problem, and this is something that we can do a lot more, we can do much better in if we diagnose it early. One of the ways in which we can diagnose it early is by getting the patients to talk to other patients in the communities. So having civil societies that are involved in maybe not particularly just ovarian cancer, because they're not as common, but we do have a lot of civil society that are working in the women cancer space, and they can be equipped with some of the knowledge and the capacity to be able to advocate more and create that awareness that we need, and we can get the patient advocates to work with them.
Thank you, Zainab, and I think that's the challenge to us, World Ovarian Cancer Coalition, to get this story out to community-based organisations, people that can reach communities and share this information. And I liked your point about the fact that in some of the low mid-income countries that this study is speaking to, a lot of the civil society groups aren't so siloed. Yes, they talk about ovarian cancer, but they also talk about breast cancer or colon cancer. So maybe we also have to challenge our biases there, and that there are advocates, especially in Africa. I work with the African Cervical Health Alliance, but almost all of those organizations talk about all sorts of cancer issues and across cancer types. So maybe we need to bring them into our conversations to ask them how this would fit into their policy-based advocacy. Ophira, in terms of the growing recognition of treating the whole woman rather than looking at us as a collection of body parts, what do you think are the opportunities to integrate cancer education and information and services for women into the existing health services, and really harness those touch points with women to build more awareness and or access for those with risk and also symptoms potentially of ovarian cancer?
Yeah, it's a great question. And if you don't mind, I'm going to take it a step up before you get to the cancer health system part, the cancer ecosystem. I think it's important to recognize that these are challenging problems, especially in today's small c climate with respect to global health financing and what we're going to see come in the near future and the intermediate term. I would say that remembering the primacy of rights in terms of women's health and women's health as being inclusive along the life course, and not just, thinking in terms of what I've heard some people call bikini medicine. You can make a mental picture of that and you know what I'm talking about. So it really takes a multi-sectoral kind of response to address some of these bigger problems. I'm going to mention patriarchy. Patriarchy is a problem. It influences the way women see themselves, the agency that women have to make decisions, as I referred to earlier, but also in terms of our whole of government response to cancer, right? You've heard some of the stories today from the people with lived experience and the clinical folks. Ministry of Health, of course, that's really where so much of this comes from, our efforts to have a small amount of funding to put towards each of these conditions. We need to be more bold in our thinking and recognize it's the ministries of finance that have a lot more power, first of all, for one thing. Ministry of Education, transport. Think about all the different parts of government and then how civil society interacts with those parts of government that can bring to bear a big problem like let's call it a fairly neglected cancer, right? And when we're talking about the cancer health system, I would encourage people, if they haven't, to look at our Lancet Commission report on women, power, and cancer, where we have recommendations. We have a session actually this week at London Global Cancer Week, where we're trying to define some indicators to look at as well, things that are measurable for which we can benchmark data and therefore determine how well we're doing in terms of progress in the long and short term. So gender responsive health systems, what does that mean when a woman comes to the first point of care? Does she feel respected? Is she asked why she came now, right? Rather than being scolded for coming late. Those are the kinds of things that we talk about. Language matters as well. And these are things that are cheap to try to correct. They're social norms in a way. And in the medical community, mea culpa, I know I've been guilty of this in the past, and trying to learn from our colleagues, our fellow people with lived experience is really key to all of that. Thank you.
Thanks, Ophira. And you've touched on this a bit, maybe just a quick follow-up. And how can we ensure that this really includes empowering women, and especially older women? We've seen that the average age was 51 years in this study. How can we bring them in and get that language that's going to speak to the community that needs to hear this this data, but also just become more aware of their risk? What do you think we can do more on there?
Well, one thing is, I really appreciate you mentioning this. I spoke recently at the International Geriatrics Congress on the Commission findings and realized that most of the talks any of us on the Commission have given so far in the first year after the report was published focuses only on premature mortality. Wow, what a missed opportunity, right? Most women experiencing cancer are older. Most women or men experiencing cancer tend to be older. It's a disease primarily or partly driven by aging and risk factors that change over time. And that's why we see differences between countries. Having good quality data is so critical. And prior to the session, we heard from the colleagues, Dr. Claudio Alemani and the Venus study, that are looking to get real world individual level data, not just on incidence and mortality of some of the cancers impacting women, including ovarian cancer, cervical and breast cancer, but also on survival, right? As well as patterns of care to understand what some of those obstacles are. So investing in cancer registration is key. Having the data to inform policy and to show people this is what's happening in our country So let's take a look and see how we can solve this problem together. Investing in registration with stage information as well. These are key things. I know they don't sound very exciting, but they're critical as well. Thank you.
Yeah, and that's a big message for the Global Breast Cancer Initiative as well, right? I mean, these are fundamental issues that we need to change our cancer control efforts. So thanks for that, Ophira. Zainab, Ophira's just said that, you know, there's a tendency to blame women on presenting late. Is there enough attention being paid to the challenges of diagnosis for women in low middle income countries, in your experience in Nigeria? And we've talked a bit about structures, finance, cultural barriers. So what more can we do, and how is this data helping shape your thoughts about what needs to be done in Nigeria?
Well, there's definitely not enough attention being paid to diagnosis for women's cancers, not just in Nigeria, but I'd say across Africa. You mentioned the African Cervical Cancer Health Alliance, which lots of us belong to. And one of the focus of that organization has been to look into how cervical cancer is being diagnosed. And there are others that focus on breast cancer. Even some of the stakeholders are being responsible and coming up to look at the data that we have when it comes to breast cancer and how we can improve the access to things like ultrasound, as opposed to just focusing on breast cancer, on mammography. So for ovarian cancer, we can do the same. We can use the findings of what is going on in our study, of the Every Woman study. We can use the findings that we have from our data, from our cancer registries, and even the global extrapolated data from the Global Can data. We can use that to advocate for more resources and also more diagnostic capacity, building the capacity of our healthcare workers so that they can have the ability to recognize the symptoms. Ovarian cancer is always said to be one of those silent cancers, but in actual fact, we find that most of the women that come up with ovarian cancer have sought medical assistance, not once or twice, but several times. And so if we have the next step would be to have the diagnostic capacity to be able to recognize it. Again, we can talk about how much the women, especially those in the grassroots, can afford the diagnostics that we put in place. So we have to start looking at things like insurance and working closer with government and those that are in charge of allocating resources for a country so that they can put more resources where it's needed, not just in research and collaboration, but definitely in access to care, and access to diagnosis is on top of that list.
Thanks, Zainab. I don't know, and when am I able to just squeeze in one more question, or how are we doing for time?
I'm not in charge of the time. If it's a quick one, Frances, is that okay?
It is, yeah.
Frances, I just wanted to touch on the topic of partnership, because, you know, this study, as you mentioned, was conducted in strong partnership with IGCS. And I feel, you know, Zainab, some of the things you're talking about now and the excitement of the following steps now happening in Nigeria are all about building partnerships. And so it's really a last question to you, Ophira. You know, one of the things this cries out to me for is, you know, what research do we need to do next? Always, you know, new findings always create new questions. So what types of partnerships are you seeing from the NCI, Centre for Global Health, that are, you know, maybe really getting down to that sort of grassroots building of capacity to do implementation science?
Right. Well, I would say the research priorities that I see, there's been quite a few named here. Of course, if everything's a priority, then nothing's a priority. I think one thing that has come up again and again is on early detection. And the sad truth is that we don't have a good means of screening for ovarian cancer. Even in the high-risk population, this has been problematic. I worked in that area almost 30 years ago when I first worked in cancer genetics. So there's a lot more we need to do to understand, you know, barring the 15 to 20% that of the common type of ovarian cancer for which there's a strong genetic cause, right? We mostly don't understand the causes. And those that we do understand some association with reproductive risk factors, much like with breast cancer, they're not amenable to primary prevention. So we could talk about that, working with other agencies. I spent time this morning at the World Cancer Research Fund here in London. They do really interesting research on nutrition and other areas that are not really covered well by other funding agencies. And I work at the NCI. I'm fortunate we have most research funding in the world for cancer, and we do a lot of prevention research, but I'd like to see other partners come to the table with that. And the last word should be those of the lived experience, people who understand what it's like to experience ovarian cancer, to have a loved one in there close to them with ovarian cancer, need to be in those discussions to help priority set.
Thanks, Ophira. And Annwen, back to you. I don't know if you had any questions in the chat, but maybe back to you for asking a couple of questions or closing today.
I think unless Frances tells me otherwise, we're probably going to need to come to a close, which is such a shame. That is one of the best discussions I've heard in a long time, and I've heard some fantastic ones. I just want to thank you, Julie, and Dr. Ginsburg and Dr. Shinkafi Bagudu. That was just phenomenal. The thoughts that you shared, the suggestions that you've given us, the guidance, and those really powerful calls to action, actually. And we're going to take all of that away. And just one of the thoughts that occurred to me was that this type of engagement, this type of discussion, collaboration, this is going to be absolutely essential going forward when we consider how the voices of women with ovarian cancer, we heard some very powerful ones today, how they can contribute to important global discussions on cancer diagnosis generally, but specifically and ultimately to drive positive change. And despite having watched very closely the development of the Every Woman Study, LMIC edition, I have to say that I am still completely blown away by the breadth and the depth of this work. And it's so important that we optimize the impact of these findings and those of our country leads. There's so many women involved in the study. We've heard very powerful testimony today. We've heard from the clinicians about the importance of making sure that their voices lead to positive change. And we begin the hard work now. So we need to ensure that women, no matter where they live, are able to afford and access diagnostic tests and treatments without financial ruin. This is absolutely crucial. We need to ensure that women know when to seek timely, appropriate medical care for the symptoms they are experiencing. We need to know that they are able to consult a doctor who quickly recognizes the significance of symptoms and that they're referred quickly to an ovarian cancer specialist. That is such an important theme throughout the study. We need to know that women are not being left down by their health system in terms of tests and delays, because we know that saving time saves lives when it comes to cancer. And we also know that women need to be supported through the whole experience in a culturally specific, culturally sensitive and location-specific way. And that they are able to get support to address very significant fears. And ultimately, coming back to voices, we need to make sure that all women have that opportunity to have their voices heard and to be able to help shape the best possible care, treatments and advocacy. And the data are very clear. I think the discussions today also give us as a coalition a lot of food for thought in terms of our work to translate all the evidence into action. So I thank again all of the panelists and Dr. Funston and everybody involved in the study. If you'd like more information about the study, please visit our website, World Ovarian Cancer Coalition.org. and if you have submitted questions or comments that were not addressed, and I apologise, we will endeavour to respond to you as soon as we can. So thank you all again.